but if you can show your face, it is so much nicer. Love to feel like we're all talking to each other, and really want this to be an interactive participation, because every one of you, hi Lauren, thank you. Every one of
I'm
you.
gonna eat dinner while I learn from you. So I hope you guys don't mind watching me while I eat.
Not at all.
Okay.
No, it's just, I feel like when we aren't on camera, then we don't tend to, you know, provide input. And the whole idea here is this is a group meeting. This isn't like a one person talking meeting, although I did develop a tiny little PowerPoint just kind of in review. So let's see. I'll wait one more minute and then we'll get started. So just a reminder to everybody that the topic that was suggested, and the person who suggested it isn't even here yet, but the topic that was requested was addressing our patients with sensory processing challenges, and not only with the horse, but also off the horse, and using, oh, there's Brianne. Okay. Brianne, I was like, okay, you better be here because you're the one who asked for this topic. And while I certainly have learned a lot over the years with regards to, sensory processing, sensory integration, as a PT, there was a long time ago, where I wondered, why I had done that, because I was a PT and not an OT. And I've certainly, come to see why it's so critical. And that's why it's helpful if you guys can put your disciplines in here so we know where you're coming from with regards to speech PT or OT. So we kind of have an idea of, of who we've got. So I'm going to take it that everybody that's on is working with patients with sensory processing challenges. So, hopefully you all can ask questions and provide input. Okay. All right, Brianne, I just saw your message. So
I think I got it fixed. Is it working?
yes, yes, we
got
can
it
hear
fixed.
you. Perfect. Okay. And Amy, we're glad you are on. So I am going to try to screen share, see if I can pull up my little PowerPoint that I put together last night. So I apologize. It is brief, but it's designed to just get us thinking. Again, this is going to be from the hippotherapy perspective. And we are also here tonight for those of you who have incorporated other strategies. I know floor time is one that was mentioned on Facebook, and I know that Megan has experience with that. I'm not sure which, who else does. If anybody has any astronaut training, listening, auditory training. There's just so many different ways to use sensory stimulation for these patients. So I'm just going to talk real quickly about the hippotherapy perspective. All right, so I just kind of named it how to address our clients with sensory processing challenges, because that's what we're here to discuss. And I apologize, I pulled just a stock photo, no helmets here. I'm not condoning that, but I loved this picture from just imagine all the sensory input that these individuals are receiving. Just imagine putting yourself in that photo. So just a reminder that when we're talking about sensory processing, we're talking about registration. So that's the receiving and perceiving of the information. And then it's the modulation, it's the regulation of that sensory information. And then integrating that information in order to put it into a usable context. And so we know that our patients that we're seeing have challenges in any one or all of those areas. And that as a result, this just creates a disordered system. And that's what we're seeing when they come to us. All right, so equine movements impact on sensory systems. Again, this is super brief, and we could take this and talk about one slide for, 4 hours. So we realize that we are impacting tactile sense. And so you think about all the things that your patients are touching and coming in contact with when they come to see you. And that's both in the barn area, in the equine environment, as well as the equine themselves and the equipment. And that when they are on the horse and incorporating equine movement, that this is in conjunction with other sensory systems being stimulated as well through the equine movement. But it makes us have to think about things like the tolerance of a helmet, the tolerance of a safety belt, if you use that, the tolerance of the equipment. I have practiced in Florida for many years, and it's hot. And so they come in shorts, and we have to think about what their legs are going to come in contact with. And, or, are we going to wrap their legs with pillow wraps to reduce the negative sensations that they may perceive? But obviously, for many, this is a motivation. So we realize some are going to be attracted and want this tactile information, and some may withdraw from it. Vision is huge. So we think about when we're on the horse, all the different visual aspects that we are promoting. So we are promoting the oculomotor system. So we're looking at convergence, so looking near and far. So our patients are looking out in the environment, and then they may be turning and looking at you or your sidewalker or a flashcard or whatever it is you're using in the session. And obviously too, then you can be integrating visual tracking and saccades, where they're looking back and forth between objects. One of the huge things that equine movement offers is visual flow. So if we think about visual flow, that is the information coming in from our peripheral visual system, not necessarily our focused vision. But this is what many of our more motorically involved patients lack. they don't get much of that. If they're not ambulatory or if they're not mobile, they're not getting that visual flow. And just remember, the visual flow is like when you're moving forward, objects, even if they are truly standing still, appear as though they are moving towards you. And that just provides the brain with such great information. And many of our patients who are not mobile lack that. And again, this is working in conjunction with proprioceptive and vestibular input with the equine movement. And we know that these three, vision, proprioception, and vestibular, are all very critical for balance.
I just wanted to add something, Carol, there to vision.
Mm-hmm.
For the kiddos that have CVI, the experience is going to really reduce their ability to use their vision. So
Are you calling CVI central vision impairment, or is that something else?
cortical vision impairment.
Cortical vision impairment. Okay.
So CVI, cortical vision impairment, where they have difficulty. It's mainly from brain damage, understanding what they're seeing, being able to interpret what they're seeing, because they are using so much of their other senses, because they are engaging their core and using all their muscles to do all of this stuff. It's going to be very difficult for them to access their vision like they would on a stable surface. So kids that are working on their visual goals first within CVI, it's always recommended that you work on one thing. They're in a stable, very supported position. So all of that kind of gets knocked out when they're on the horse. So don't expect them to be able to, quote unquote, see as maybe they normally would in a classroom environment or a home environment. They're going to have more difficulty in this environment.
Yeah, definitely, because they're having to process so much more information. So that makes so much sense, Brianne. With regards to the visual flow, though, that is peripheral. With peripheral, we don't necessarily, that's not our focused vision, and so it's more just the idea that we're seeing something and perceiving movement, as opposed to central vision, where we're trying to focus on anything specific. So, you're going to have the focused vision is going to be the things like the convergence and divergence, the visual tracking and the saccades, and then you've got the peripheral vision, such as the visual flow.
Yeah, they call that, I know my son's CVI specialist will call that dorsal versus ventral stream vision. So if somebody wants to
Okay, so dorsal is more like towards the back, the periphery.
Yeah,
Okay.
so a lot of kids with CVI that are lower on the scale that don't have functional, like they have functional vision, but they're maybe not reading or able to do a lot of the very upfront, very detail-oriented type work, focusing, like you said. They use a lot of that stream to process information.
Yes.
Instead of focusing. So that's why you don't see them sometimes looking at an object, because they're doing a lot of processing this way. Which doesn't make it super functional when it comes to education, but that is actually how they learn initially how to use their vision, is that everything kind of passing by, I kind of see things, but it's not anything in detail.
Right. Okay, good. Yeah, thank you. Yeah, and so things like feed forward and feedback, that is assisted through that visual flow. And then again, because we were talking about this being in conjunction with other senses, including vestibular, just something to keep in mind too, for those of you who haven't thought about this in a while, is being cautious about the combination of vision and vestibular. So again, talking about that visual flow, we are accustomed in life to moving forward and having things appear to move towards us. So when we do put our patients in rear facing, on the horse, we're giving them a completely different input in that things are appearing to move away from them. So that's a mismatch with the vestibular information that they're getting while they're on the horse. And so if you have a patient who has sensory issues and doesn't appear to be handling that well, or you end up with behavioral issues when you put them in rear facing, consider that may be one of the causes. All right, so with regards to stimulating the vestibular system, we have so many different opportunities to alter the input that we are providing based on the velocity or the speed that the horse is going, the tempo that the horse is using. What kind of directional changes are we using? Are we working, down a lane on a long straight line? Are we using a full arena where we're making either end? Are we integrating more directional changes with those circles and aid and serpentines? So all of that is providing a lot of sensory input, and so we have to be considerate of our patient tolerance of that. Just the surface that the horse is walking on, on a grassy area or a packed dirt lane versus the softer surface of the indoor arena. So all of those are going to provide different amounts of stimulation, and not only to the vestibular system, but very much the proprioceptive system as well. Just, if you're using inclines, if you have the luxury of kind of sloped areas, you can challenge your patients in many ways, and certainly vestibular is one of them. And then, of course, the position that we're placing our patients in. And so we have to be really considerate of that. So you see this patient here's rear facing. So, we've already pointed out that, that aspect, but sometimes we put our patients in prone over the barrel or prone, in rear facing, where we got that head down, and or, heaven forbid, supine. Everybody's going to tolerate these different. Some of them are going to be seeking these positions, and some of them are going to be absolutely very resistive to them. So always keep in mind, how much vestibular input you're giving with these different directional changes. And then, of course, proprioception. So we realize that we're giving that, it's basically coming from the ground into the horse's hoof, up the horse's leg, into the horse's pelvis and spine, and being transferred, continuing up into our patient. So provided with every step. Obviously, every equine is going to be different with regards to how much proprioception they provide. We know that horses that have more upright fetlocks and shoulder angles are going to offer a more proprioception than a horse that's got a lot of shock absorption. Obviously, even just increasing impulsion of any horse is going to provide a change in proprioception. And then, of course, the equipment can alter it. So we may diminish some of that movement through the use of a saddle. Okay, so again, forgive the choice of pictures here, but just think of yourself, if you were in the situation of the rider on the left, what your arousal level is going to be at versus this young lady on the right. And so, we don't we're not always privy to what our patients have experienced just before they've come to us. And they may have had one of those yeehaw moments before they come in and they're, hyper aroused. And we may, be seeking to reduce that arousal level or vice versa. But then we also know that in general, some of our patients will tend to be more hyper responsive and much more cautious, or those who are hypo responsive and then maybe more of a sensory seeker as opposed to a sensory avoider. So we have to really get to know our patients to know what it is that their needs are. And then this is just the last slide, just kind of, thoughts on how does hippotherapy impact sensory processing. Obviously, we can progressively challenge our patients' sensory systems. So depending on your patient, they may not even get on the horse initially. It may be something just for them to get accustomed to the environment, to be around the horses, then to gradually progress to being able to get up on that mounting ramp, and then get on the horse and experience the movement. And you may choose a smaller horse or a horse with less impulsion initially, and then be able to progressively increase the amount of movement that the patient is receiving. So we are modifying and grading that input. And, we haven't even talked about olfactory or auditory, but those are all also senses that our patients are experiencing that can also be modified and graded. But we can also make it be consistent, and it's certainly ongoing while they are on the horse. And I realize that when they receive that input, they're integrating that input sometimes for hours. So vestibular stimulation especially can be experienced, or the processing can go on for, even into the next day. And then appropriate activities promote integrated responses. So it's all about what we're choosing to do with our patients, both through the selection of the equine and the movement and the equipment, and then overlaying any other activities that we're doing. So many, many, many opportunities to grade and modify the sense experiences. So that is my little intro to this topic. And now it's just kind of up to you guys to present us with a question or give us a scenario of one of your patients, and everybody collaborating on ideas. Brianne, you said you had some situations. I'm hoping you will bring those up.
Sure. I actually had a couple kiddos. One that comes to mind was a little boy. He was, there's a laugh myself, it's 9 or 10. He is definitely a sensory seeker. One of the biggest issues that we had with him is trying to get him to do other tasks. He would focus a lot on chewing on the strap from the helmet. So, he was very, trying to get him away from that kind of preoccupation. And one of the things that he loves to do to kind of help him refocus, I guess would be the best word to use for him, is just some short trots. He was actually a very strong kiddo. So most of what we did with him was sensory type stuff and working on core and where he was at in space. He had a diagnosis of autism, mostly nonverbal, but had some words. He also had some issues with, and his mom was great about this, about his jeans or certain clothing that he wore. They had a hard time finding ones that he was comfortable in because if they're too tight, they bothered him. If they were falling down, they bothered him. And sometimes he just had to go potty. So trying to know the difference, we relied on mom a lot, and she was great about saying, oh yeah, it's definitely this and not that. So those type of things that kind of interfered with a session or, stop starts the session. So he really liked that input of the small trot. We had a horse that was the slowest trot you could ever see. And it was just enough to kind of get him to like giggle and pay attention and go, oh, great. And we were able to get engaged with him for a little bit longer. And then we had another kiddo who was the opposite. So same diagnosis, they were almost the same age. But we were working on helmet comfort and tolerance. He actually did really okay with the belt. He was fine with the belt. He wore the big headphones. I think you've actually seen him in a couple of pictures of mine, like kind of that blocks out all the sound, which is ironic because his obsession was watching music. So a lot of Disney type movies, music, but the same song over and over and over again. So he was kind of more defensive where it took us probably 3 sessions to just get him comfortable being on the horse, learning how to mount the horse. He would at first get on the horse and jump right off. So, it was just a little too much for him. Getting up on block was a little hard. He felt a little unsteady up there. So he was the opposite. It was like, oh, geez, this is too much. And it just took him a little bit of time. And we talked to his mom because she was worried. He was a level 3. He was a little bit more intense of needs. And she was just hoping to find something he would be interested in and that he would participate in, because up to that point, he really was not cooperative enough to be able to play in any adapted sports, to do anything really. So kind of 2 ends of the spectrum that we really experienced. And both of them were very mobile, didn't really have a lot of physical disabilities, but the sensory issues were big. Core stability, knowing proprioception, knowing where they are in space, and just the communication was wonderful to see. We don't have a speech therapist where I work, but just seeing the interactions and the verbalizations improve while they were riding was wonderful, or doing therapy, sorry, not riding. But yeah, while they were participating, the increased participation, and it just took a lot of time and patience. And the parents were actually very integral in being able to kind of decipher, okay, is this too much for them? Their behavior the best since they were nonverbal. Is this too much for them? Do you think they're getting overwhelmed? Or do they work through it and they're okay? So the last boy I just mentioned, he's kind of one of those kiddos that, okay, let's let him go. And he actually settled in pretty easily. But, when you first met him, you're like, oh my gosh, I don't think this is going to go well. But we had some very tolerant horses, very patient horses. And that really helped. Was just, I told her, I said, we may not get up on the horse the first time. So that's okay. We're just working on getting him comfortable with the process. And then he did great. He tolerated sidewalkers. He tolerated hands on his legs, support on his legs, that type of thing. So I know those are the 2, yin and yang experiences that we had there.
Well, I think you've brought up a good point, Brianne, is that no 2 kids with an ASD diagnosis are the same. And that's why it's so important for us to have to assess and determine the needs of each. And it sounds like your first person, even though they were a sensory seeker orally, it sounded like in other body parts, not so much, if didn't tolerate jeans because of the seam or because of the waistband or whatever. So there was kind of, you had both going on there, and that's not uncommon either. So does anybody here want to give any comment or feedback to Brianne with regards to either of her?
Yeah, I appreciate, Brianne, hearing about your clients and what a great job you're doing with them. I think a lot of what we do sometimes is experimental, but we just always have to go back to, what is the child seeking, which is what you're doing. What are they doing? Because they will tell us. I think one thing that I like to do is test. Usually I can do that even with some of our more difficult kids, to just sort of test if they have an ATNR and an STNR reflex. Those are helpful for me. Sometimes we'll say, oh, the kid is really strong, but actually they're using extensor tone to hold himself up and they're actually really tight. And once you get them to relax, they actually have a little bit of low tone in their core. So sometimes if you can even get them in quadruped, you'll see that they'll try to go up on extensor fingers. They don't want to go down flat. Because they can't maintain that, and their shoulder girdle stability will be actually very weak, and their core. So, the other thing is determining, is the child more gravitationally insecure, or are they really seeking and have probably, if you did a post-rotary nystagmus, as 0 on the test. Usually when they have a 0, they really seek it. They're bouncing off the walls. And if you test that they have like a 2 to 3 seconds of post-rotary nystagmus, that's generally when they're really insecure with movement. But both of them can have really underlying tone, and they can both have an autism diagnosis. It's really what, like Carol said, what presents, it's always different. But it sounds like you're going at it just the way you should, going slow with the one and providing a different type of trot, the very smooth trot, to get them to receive it and slowly get used to it. But, and then doing some visual tracking with balls and things to see if they can actually track and cross midline. Generally, when they have those reflexes, I've found that those reflexes, they absolutely cannot. And they'll have skips and jumps. And so playing games, sometimes they already know that they can't, because if they're like 7 or 8 years old, sometimes if they're presented with a game. So doing a little more hand over hand with things is very helpful. And then reinforcing it with a trot afterwards, because they actually like that and they need that. So we use the horse in our program kind of that way, like it's used as reinforcement to do some of the other things that I want to have established, in addition to, of course, the gaits and the serpentines and all of that, crossing midline and reaching and getting. So yeah, it sounds like you're doing a great job. I highly recommend a SIPS course. David Belaski in Chicago has done some. He came to our clinic and actually presented to all the therapists. It helps a lot to understand from a SIP certified therapist some of the things that we're doing, and helps us better have an understanding of the clients. Also, I highly recommend any reflex courses. So those are just a couple things.
Yeah, those are
And
great.
just for clarification for everybody, because I'm not sure, is everybody familiar with post-rotary nystagmus and what she was referring to? I'm going to guess probably not. So you want to just discuss how you test that and what you're looking for?
Well, some of the kids that are very involved, I'm not going to test, but if others, I will. And I'm using right now just a chair that spins, because it's easier and supportive for sitting in, and they do crisscross applesauce, and then we put their head in like a 30-degree angle to 45 almost, so that you're getting all the semicircular canals activated when you put the head and lower it. And then you do a spin of 10 seconds, 1001, 1002, 1003, one direction, and you just have them stop, and their eyes are closed at the time. And then you have them look straight ahead past you, and you count how many times their eyes will diverge back and forth, and then in a nystagmus type of reaction. And there's, Jean Eyre's research has shown, and it is actually referred back to by other neuro people as well, to show that there's association with that, with learning disabilities, and your brain, it hasn't organized itself properly yet or developed. I don't like it to say that it's, damaged. It just, when I do it, it kind of gives me an idea, a starting ground of where we're at. And what happens is, with just riding a horse, it's amazing. Just riding a horse and doing what we do, the child's nystagmus can go. We've had some children, let's see, both of our brothers, they came in at 12 and 14, and now they're 13 and 15. And their post-traumatic nystagmus is now at within normal limits after about a year of therapy on the horse. So
And you want to
that's
remind
kind of
everybody
amazing
what's
when we think
normal?
about 14 seconds is within normal limits. So if they're 0, they're usually bouncing off the wall. If they're under like 5 or so, they're usually very, very pensive about movement. And then 7 to 10 is getting better. And when that happens, we're also finding that the motor planning goes right along with it. And that's where Gene Ayers also shows that learning gets better, reading gets better, focus gets better. And motor planning actually runs through the same pathways as some of our reading and writing. And so what happens is, we can work on these things, and then their schoolwork gets better. All of a sudden, they're tolerating the classroom. All of a sudden, we're all wired certain ways. Like I myself, I can't handle bright lights for a long, extensive period of time. And I know that I myself had some sensory processing as a child, but we learn ways of adapting, but we get within a realm that we can actually function and progress and go forward. So it's just been fun to see these two young men. Now they're ready to graduate, which is sort of hard because they like it, but they're not going to be, they need to move forward. They're starting now with their robotics class, and they're starting now with baseball, and what was the other one? Cross country track. So that's kind of the goal, is to get them to want to go forward. Now these are, they have a diagnosis of autism. I sort of in my brain think it's just a sensory processing thing, a reorganization thing. We just need to work on it. I wouldn't say, if in my terms, that they're autistic, but that's the label they came with. For lack of better things to diagnose them with, whoever's doing all that diagnostic evals at the schools and treatment centers. But so those are like your school kids that come in with kind of ADHD, autism types of things. But when we have some more severely autistic kids, I found that I can't do much of the testing. I'm lucky if we can walk from point A to B and get on the horse, and we move slowly. And given time, the movement of the horse, sometimes they will become, once you figure out that they understand very simple commands, then we can use that to our benefit. And I say sort of in a manipulative way, in that I now know that they understand. So now we get them to cooperate and then go forward with the therapy, because they want the movement. They just love the movement. And so some of those little autistic kids that come in like that, sort of a little bit very, very, very dysregulated, unable to do it themselves, have the things in their mouth, chewing and sucking away. Once we get on the horse and get going, they just love it. Of course, you see that. And then I sometimes let them kind of play around with that as well. Sometimes they'll want to lay back, and I'll say, oh, you want to lay back? Okay, well, we can lay back, and then let me provide you with this pillow, and we'll walk laying back. Because like, Gene Ayers always says, the child will go towards what they need. When I watch that, though, some of our children who have been out there not getting what they need everywhere, they have some behaviors that are really outlandish, and it helps them to get out of things. What's the better word? I'm not one for words right now after a 9-hour day, but so then it's a matter of learning learning new ways for them to behave, like giving them new options and new avenues. And it's been fun to see little kids who couldn't walk from the door to the arena or barn or to the therapy without mother dragging them along. To now they walk in, grab their helmet, put it on, and walk to the arena. So we have a magical tool. And Brianne, it sounds like you're doing a great job with the two of them. I don't know. I'm just going on here. I'll let someone else talk. Thank you.
Well, I have a question, follow-up question for that. Oh, sorry, Brianna. So Sharon, I'm really clueless about all the nystagmus stuff, but I took notes about what you said for like how to do the testing, and I vaguely remember that from 100 years ago in PT.
Oh, yeah.
But I don't remember exactly what did you say you're counting? Is it like beats as that goes across, or is it how many times their eyes go?
The eyes kind of go like this, back and forth. They should do that.
Okay,
and
right.
you count how many seconds you are seeing that happen.
Oh,
Yeah.
so how long that lasts?
Yeah.
Okay.
All
right.
Yeah.
So 0 is the child who would be bouncing off the walls, you said. And then normal
Yeah.
is.
Excuse me. I'm sorry. It's how many I see, not how many seconds. We go 10 seconds and stop and have them
Oh,
look
okay.
up. And then it's how many beats we see till it totally stops.
Okay.
Yeah. And you kind of want them to look beyond you. Not all of them will, but you tell them, look beyond, look back, so that they're not trying to focus. And, a lot of times people go, oh, but they'll get dizzy or they'll get sick. That's, if they say to me, oh, wow, and they're like, whoa, I don't need to test the opposite direction. I now know if they have a big issue. And then usually I'll say, well, let's get up and jump, up and down, jump, 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 because that deep proprioceptive will help that go away. Or blowing like that, blowing out 10 times. That'll help that kind of, and it does kind of calm it down. Yeah.
Okay, thanks.
Yeah.
We have some other questions for you with regards to how do you determine which direction you're going to first?
I don't usually, I just go either direction first. I don't really have any knowledge of anything different than it doesn't, just either direction. If someone else knows some other research about that, then I have not.
Okay.
Yeah.
And I see there's Brianne, you've got some conversation going there, so I'll just let that continue.
Conversation, sorry.
Oh, shoot.
Like I'm one of the few PTAs. I don't know if there's other PTAs around, but I feel like I'm one of the few assistants.
Did anybody else have any comments with regards to Brianne's?
I do. In regards to your first patient who was seeking chewing on the helmet strap, have you tried redirecting him to a chewy tube or providing him with opportunities to chew on other materials such as jewelry, chewy tube, or even blow bubbles or a musical instrument that's oral motor?
Yeah, he's very, very fixated. His mom will bring some things that he likes, but he doesn't like, it's kind of unusual. He doesn't chew like on his clothing or anything else. This is not a behavior that he does. I think it's more exclusive in the environment because it's there. So we have tried to redirect, and he can do, like I said, when we can get him to refocus, he leaves alone for short periods of time. And some days are better than others. So again, the sensory seeking seems to change depending on the day and his fatigue level on how much he can be refocused. But yeah, we've tried a couple of different things. We didn't try the jewelry though. I think that might have been nice because it's right there.
Mm-hmm.
The helmet just sticking right there. we were gonna try. He's discharged right now. But we were gonna try maybe a different helmet that maybe, we're figuring out some way to kind of keep it out of sight, out of mind type thing, I guess.
Yeah. What I've done with mine, you know how sometimes the Ovation helmets come with a fabric piece that Velcros around the buckle and the strap? I'll try to do that. I'll try to make sure the excess strap is secured with the rubber band, and then I'll put that fabric piece with the Velcro around it so that it's more snug and less hanging. And then I just, keep a chewy tube or something, a jewelry around their neck so that it's really accessible. And I'll just immediately direct, we cannot chew on our helmet strap, but you can chew on this. Always, what they can do instead of no, don't chew on that, take that out of your mouth. I can't stand that when parents tell their kids, no, don't chew on your shirt, or no, don't chew on your hair, or no, don't chew on that helmet strap. Always having something to replace the behavior with. Because as I think Sharon, it was her name, talked about, the kids will gravitate toward what they need. So if he's chewing on his helmet strap, then he really does need oral proprioceptive input. So he needs chewy, crunchy foods or something oral prop.
You guys are awesome. I love these.
What I've provided on the horse before are freeze-dried strawberries or freeze-dried other fruits, or even just dried fruits, anything really chewy you could even maybe give them on the horse. And everyone, I've done all of the SIPT certification. So if anybody has questions, I'm not sure about the PTA question. When I took my SIPT courses, I don't recall there being any PTAs or OTAs in the course, but typically courses that are offered for therapists, OT, PT, speech, are usually also applicable for assistants. So I would reach out to whoever's in charge of that these days, but I have fully completed my SIPT certification if anybody has any other questions. It was really good.
Yeah.
And I thought that they weren't offering it anymore.
I don't know.
I think it's now through Classy. I don't think you can do the WPS SIPT anymore. I think you have to go through Classy, and then it's revised again a little bit.
Yes.
Still, and I put in there, but anybody who's not looking at the chat, I'm not sure about the PTA question, except that at least when I did it, it was 4 different sections. So I can see them not allowing aides or assistants to do like the testing portions, but I would think if you reached out, you could do the 1 and 4, because you could do it separately. So they had theory, and then there were like 2 weeks worth of test administration interpretation, and then a week on treatment. And you were allowed, when I did it, to do it in the blocks of either all 4 or 2 and 2. So I would just follow up and see if they still have any of that format, and you can do potentially the theory and intervention piece and just not the administration interpretation parts. But I'm not sure how it's structured now that it's Classy.
That sounds right. When I took it, it was back in the day. And yes, the first course was all about theory and just what sensory integration is. The second course was how to administer the assessment. So it makes sense that that one wouldn't be applicable. The third one was how to score and interpret the assessment. So it makes sense that that wouldn't be applicable. And then the fourth one was intervention. And that one, obviously would be applicable to an assistant. So yeah, maybe an assistant just can't get the full certification, but they can do the courses.
Yeah.
Or
Yeah.
I actually think that's the website I looked at. It was classy.org. And that's what I was talking about with, it was a bachelor's or something, I think is what it said. You have to have a bachelor's. I'm like, well, I know there's PTs that have bachelor's. Still, grandfathered in, but definitely, I have a bachelor's, it's not in PTA. So I'll have to look more. And are there any other maybe sensory coursework or CEUs, especially on the PT side? I feel like we're not as, that's not, a big part of our education, and we rely a lot on the OTs to do that. And I don't have OTs. So, kind of trying to find ones that you guys probably recommend or use a lot, since I probably can't do SIPT. So
I think STAR has a lot of really good ones. That's down in Denver, but they do a lot of good courses. And then I've done a lot of the ones from Sheila Frick, like the therapeutic listening, but she has a lot of really good ones. that you could do that focus on just vestibular intervention and sensory programming and that kind of stuff. So that might be more digestible to start out with if you're not as experienced in SI. It might be a good starting place. And then I think, were you the person asking about the autism stuff, or was that somebody else? Because the floor time and the play project stuff is really good for that as well.
I was actually hoping, Megan, that you could, yeah, it wasn't Brianne that asked that particular question, but I was hoping that once we had answered Brianne's question and everybody had given input to segue into that, those areas and discussing alternatives to hippotherapy or adjuncts to incorporating the equine movement. So did anybody else have anything they wanted to add for Brianne before we move on to that?
Yeah, in regards to the question about courses, this isn't a course, but I've really enjoyed the OT Butterfly podcasts. She talks a lot about sensory, and this would be free. You could listen to it in the car while you're driving to work. It wouldn't be for CEUs, obviously, but just if you wanted to educate yourself a little bit about sensory integration, she really speaks in layman's terms as well. So it might be kind of nice if you're entry level in this sensory integration topic. She just speaks a lot about really practical ways that can help. And I think it can really shape your understanding of SI if you would like to learn more and grow in that area. The
And it was
podcast
called
done by
OT Butterfly?
Butterfly, yeah. And it's an occupational therapist who has a daughter with sensory processing challenges. And so it's really designed for parents, which I think is even better because then it's broken down into really basic terminology and practical solutions. And it's also something that you could potentially recommend to your families. She has a lot of great printables as well, explaining sensory, explaining the proprioceptive system and so forth that you can print out.
Mm-hmm.
The other one that's pretty good about if you just want handouts and those kinds of things is Sensational Brain. Has some good stuff, and you can get a membership into their database, and then you can do print out like home program little icons of a blue person doing a sensory activity. But she breaks it up into like seekers and avoiders, and if it's regulating or calming or alerting. And so that can be helpful if you're just starting out into it too. So you can see what for most people would be an alerting activity or a calming activity. And that can be helpful for home programs or therapists, I think, if you're not as comfortable with SI.
Yes, the OT Toolbox is another good blog that sends out emails, and they have a lot of free printables as well about sensory.
Thanks, guys. This is awesome. So Megan, I know that floor time was one of the specifics that was mentioned. And I think you said that you were experienced with that. Can you share that information?
I will try. The thing that I do like about the floor time and the DIR model is that it really breaks it down into your individual differences, but I like that it has levels. So, and it doesn't categorize saying if you're at a level 2, you're only at a level 2. Obviously, with everything, you can reach out and be primarily functioning in a level 2 and then branching up to a level 3 sometimes and down. And I think that's what's really hard for families to understand, is that even though they might have skills in like a level 3 or 4, it's not always functioning there. So I shared in there, and I forgot to put the www part in front of it, but the little website. So I just pulled up some of the information on the DIR levels, because of course I couldn't find my printouts. But level 1 is regular self-regulation and managing your emotions. Level 2 is engagement. And then like level 3 is more of a two-way communication. Level 4 is some social problem solving. And then level 5 is beginning to have more words and ideas and imagination. So they can branch across any of those things. But I think, at least when I did DIR, they were saying that OTs, we really like the level 1s and 2s because those are your really sensory based kids. And that's where we kind of dive in. And you're really working on engagement and attention and self-regulation in those levels, and just trying to stretch out that period of self-regulation. And then, I don't know, I tend to struggle more when they're in level 4, where they're starting to have that problem solving, because that's when sometimes they have a higher level and sometimes you're like all the way back down to a 2. And you're like, okay, but yesterday you could explain to me in a nice, great sentence all the things. And then today, boom, level 2. So it's really just meeting them where they're at. And it gives a few strategies. And I probably should have prepared to do a presentation or anything, but some of the strategies that you really use is they talk about getting circles of communication, and that can be verbal or nonverbal. And any speeches, feel free to jump in here on that. But so like I could extend my hand with a toy and they could reach and grab the toy, and that would be me opening a circle and them closing it. Or they could point to something and I could say, oh, you see the ball. And so then they opened it by initiating communication, and then I closed it. And it's an easier way to track some things for those kids who are nonverbal and only partially engaged, because you can see, can you extend those circles out? And so like on the horse, if they point to go and you stop and go and stop and go, or anything like that, or and I think more hippo related things, but just kind of noticing the subtle parts in the communication and labeling it for them, or initiating a conversation can help with that. And then they talk about taffy pulling, which I think speech therapists are really good at, when you're kind of playfully obstructing what they're doing so that you're drawing out the engagement a little bit longer. I just do a lot of it at this point. I don't label it so much. So I'm sorry, that might not be the best part, but a lot of it is more focused on engagement and attention and self-regulation versus some of the more ABA models or the teach models that's like task completion. It's following the kid's lead, which sometimes can be tricky with horses. You know, we have to be safe. But or noticing what sensory needs that they're not getting met or that they're seeking, and helping them to seek that and label it. So like they might be climbing up a ladder, and instead of just spotting them, you could make a noise each time they hit it, like boop, 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 or up, up, up. And you can kind of label it and just kind of keep that engagement. They also talk about joining them in play. You know, a lot of times kids might be lining up a car and his therapist are like, let's go straight to playing. Well, they'll probably turn around and reject you if you try and change their play scheme. So the first step would be letting them, or them letting you rather, be part of their play. So maybe you would line up the cars with them, and pretty soon they'd be like, oh, finally somebody who gets me. So that would be one way to do that. And then eventually you could put a car out of place and just see how they handle it. Can they stay regulated? Are they going to communicate with you? But don't start by messing up with their play scheme. You know, they might be throwing a ball. And so if you just try and get them to put the ball in the basketball hoop, you will probably fail. But if you stand next to them and throw the ball next to them and kind of look at them each time, you'd be like, whoa, yeah, we're throwing the balls. That's awesome. Maybe then they'll let you change the play. So I think so often with those lower functioning kids, will come in and be like, oh man, you're totally just spinning the spinner. And I know I'm like, please stop spinning the spinner. Let's go do something functional. But sometimes you have to spin a spinner next to them for a few minutes until they finally acknowledge that you're in their world and you're in their space. And then maybe you can spin the spinner sideways, or like just change it up just a teeny bit and see if you can keep the engagement. Or you could take a more task reward, like spin the spinner 2 times, do a task, but that's not really floor time. That's more of an ABA type approach or a first then approach. And you wouldn't introduce those in floor time until the child had regulation and had engagement. So it kind of gives you that play scheme. Does that make sense? Let me pull up my levels again because I never remember them all. But yeah, if they're still really working on self-regulation and managing emotions and the engagement and relating part, you're not going to demand two-way communication, right? You might introduce it, but that's not going to be your goal area until level 1 and level 2 are more solid. We would say sometimes they're a holy kid because sometimes you do get a child who's in level 3 and has that two-way communication, but their modulation and regulation and engagement is terrible. So you would still want to go back and kind of build that foundation. And I feel like I can always tell the kids who had a lot of DIR because they will engage with you and they will stay more regulated, even if they don't have perfect verbal skills, versus the children who can label everything, but don't care if you're in their world at all. They're like, oh, I can label every single thing, but you can come or go. And I'm just going to keep labeling because I know to say red, blue, orange, apple, cow, but it's meaningless because they're not communicating with a partner. So that's what I really like about the floor time and that focus on affect and engagement and like changing your voice or just meeting them in their play. You guys have any questions? That was the 5-minute of like a 5-day class, but
Are you doing this in conjunction with equine movement? I mean, obviously you can do it not, but can you do this in conjunction with, or is this completely? I mean, it sounds like you could, but I'm just.
I can with the kids who are a little bit higher level, if they are regulated and if the equine movement is regulating for them. The hard part is I'm not going to be completely child-led when there's a horse involved because of safety reasons. And I do explain that to family, so, you know, like, but you could, if they are emerging two-way communication, you could get them to trot and label it and do that kind of thing with it and maybe make the noise. Or I will label it like if they're bouncing, be like, oh, you want to bounce. And then maybe you could trot a few steps and then they could bounce again and you could do that. But I don't usually do the level 1 and level 2 with hippo as much. You know, I might use it separately to try and meet their sensory needs so that they become engaged. Like I'm thinking of a little boy that I just started and we are actually doing more DIR in the arena, but he could care less about the horse. He doesn't want me to touch him. So he's not on horse right now, but they are coming in. And today we spent the day rolling a ball up and down the ramp. So, and kind of labeling it. Every time he'd go up, we'd talk about like up, up, up goes the ball. And then he'd roll it down. And then when he was pretty good and consistent with that, the ball would magically get stuck and we would have to problem solve to get the ball unstuck. Or like we have the basketball hoop and we tied it off. So I finally did get him to throw it in, but we started with just throwing it back and forth because that was where he was at. And then I showed him how he could rocket it up. So we had a nice little sequence going. And we were labeling a lot of things with noises or sounds. And we were adding some stop and go in there. So it was very floor time based, but he really doesn't acknowledge the existence of the equine at all. And he couldn't tolerate a helmet and he did not tolerate me picking him up, but he will let me put him on the soccer ball. Like the giant horse soccer ball, which is basically a therapy ball. So he'll push that around and then he'll stop and he'll ask to go up and we'll go up and then he might. Sometimes he'll say bounce and sometimes he can't. You know, his verbal approximations come and go depending on how regulated he is. And so we'll bounce and then he'll go back down. So that's a very floor time in the barn session. And I have had some kids where I do use it with the hippo, but probably less so at those beginning levels, unless we're just really working on regulation, which the horse is really good at.
Okay, so you might incorporate the equine movement and then that when that part of your session is over, then engage them more in the.
But you can definitely work on the circles on the horse, like the circles of communication, and point anything, because it can be verbal or nonverbal. And so you can acknowledge that. And then I think you can still do playful obstruction and some taffy pulling with the horse and some of the other principles. It's just a little less child-led.
Right.
Carol, I can talk a little bit. That was a great summary, Megan.
Thanks, Jody.
I've done the play project training, so I can talk a little bit about that. It's essentially the same. It was Dr. Rick Solomon did our training here in Michigan, and with a group of us, and it's all built off of floor time. So he uses the same levels and everything. And there's some.
And what is it called, Jody?
It's play project.
Play project. Okay.
Yeah, play project. And it really is built off of floor time principles. And I think there's just some really nice things. For me, when I took it, it was just such a game changer in working with kids with autism, but really all kids, because it gets at these basic foundational skills, which incorporate sensory processing. So this idea of first and foremost doing, Dr. Solomon always says, have fun, do what the child loves to do, and the child will love to be with you. So as far as like incorporating it into hippotherapy sessions, like the kid who liked to trot and he smiles and giggles, like those are the things that we want the kids to do that are not maybe engaging as much. And so those, I kind of keep those running lists of, this is what this kid really likes to do, and this is how I can connect with him. And then playing at the level that's just right. That's another one of the principles. I'm sure that's in floor time too. And so, kids are going to have this ebb and flow of regulation where you can't get them engaged. And what do you do? And you want to, because the parents are watching, but sometimes just that movement of the horse is enough. And in the play project, I don't know if floor time has this, they have rabbit hole techniques, and I can share some of these with you. I share them with parents. And it's, what do you do when kids have gone down that rabbit hole and you can't connect with them? And like Megan said, sometimes you can just be with them. Sometimes you can imitate what they do. You might change up the sensory mode. So if you're walking and the pace is really repetitive, maybe I'm going to do some half halts and kind of see if I can get them engaged. So I'm changing something up about that. So I think like the principles of play and floor time don't apply like in the strict sense, but there's so many awesome foundational concepts that really apply, I think, across the board. And I know Play Project does training. They just did one, and they're all online. I think they're like $350. And I can share, they send them out when they do these, and they do them for parents and for professionals, and just kind of an overview of all of the techniques. But like Megan said, it's a parent coaching model. So I have a whole folder of all these techniques she's listed, and you kind of look at where the kid's at and you go, okay, this is what I'm going to try. So I think it has a lot of application in the hippotherapy setting, just not in the strict sense. You kind of cherry pick what you want.
And there's a lot of overlap with sensory. Actually, most of mine came from Play Project too. So
yeah, and it's like sensory motor play is, for those kids that are hard to engage is 9 times out of 10 what we're gonna go to, because that's what engages them. And it depends on what you're working on, but I would think in your sessions you're always working on, and you want them to be engaged so they can participate. So looking at all of those sensory needs, and then also, what is that intrinsic, what's fun for them, what regulates them, and what's fun for them. So I love it. It really changed my whole lens. It's such a great perspective. But I'm happy to share, if anybody wants you know, if you think, oh, I would love information on like taffy pulling, I have, that's what they provide, and Megan probably has that too, or rabbit hole techniques, or, just some ideas from that approach.
Well, what would your approach, Jody, be for Brianne's first patient that she described? I know that Amy already gave her some ideas with regards to how to modify the helmet to get the strap so that it wasn't dangling and not wanting to put it in their mouth. But if they're, say, orally, do you have anything specific for that?
For which part of it?
For the sensory seeking, for wanting to mouth things, like how would you address that using, or are there strategies using this play project to address just a real intense need for a certain sensory.
Yeah. No, that's a great question. I think that it sounds like it's just mostly in the equine environment. Is that right, Brianna or Brianne?
Yeah.
Yeah. So it does make you wonder, just from a regulation perspective, or a couple things. Is it that I'm suddenly so overwhelmed because it happens as soon as the helmet is on, or when he's on the horse?
I'm wondering if it's just because it's there,
Right.
Even with me trying to kind of keep it tucked in there where it's supposed to be, he will sit there and fidget with it to get it out. So I think that cover that the ovation helmets have might help with that. It might be a little harder for him to get that uncovered.
Right.
I think it's the same thing as the jeans, it's there, and it's kind of like, I wouldn't say bothering, but yeah, he just is aware of it. So it's there to play with.
Right. Yeah. So maybe it isn't so much a regulation thing. I was just going to say, so he has this kind of aversion or issue with his genes, so it might just be bothersome. So I always say, if things are a problem, even when I go into homes, and if a child is constantly trying to get into, the box on the table, instead of trying to, deal with that behavior, remove the box. So I think that's a great strategy to try. And then if it continues, then you go, well, maybe this is a way to regulate, because it's a really overwhelming environment. So now how can I meet that need in other safe ways on the horse? And there were already some great ideas. I use a lot of vibrating chewies too. Like my kids usually love those that seek a lot of input. So yeah, I would first remove it and see if that doesn't help, like you're planning on, and then providing an alternative. And I love that he loves trotting. I know we do a lot at the walk, but Carol, you talked about like all that great proprioceptive input with horses that have that, more upright shoulder and more concussive motion. So he smiles when he trots. Those are great opportunities to engage.
He giggles, actually. It was really cute. He just giggles and laughs. So it's the cutest thing.
Right, Megan, is that not like floor time? Like,
yeah, that would be meeting
love.
them where they're at. And if his need is for a higher level of sensory input, I think what you were talking about is, why is the oral there? Is it because it's distracting? And I'm sorry, I missed the first part, but oral is usually very regulating. So I would try and eliminate the helmet thing, but also have something available, and then start with trotting. If that meets his system needs, or see if you can get a different horse that has a more concussive gait, because that vertical displacement's more organizing for a lot of kids. Then you might have to run less.
Yeah.
Which is a bonus.
Well, her trot was very slow, thank goodness, because she was a retired lesson horse. So she was very used to carting little kids around. And her walk is like the slowest walk you've ever seen. So he probably did need, her trot was a very manageable trot. Thank goodness.
Okay, well, if you can trot the whole time, go for it. I personally cannot. So you might want to start with trotting or think about a horse that has a little more impulsion and especially more of that vertical displacement, because that's usually the most organizing from a sensory perspective. And then maybe he can request more trotting or something like that. So start out with that earlier and then have that circle of communication where you can request it. But yeah, that's definitely in the floor time thing. I just always think of it as play-based and child-led, which doesn't necessarily mean child fully controlled. You know, we still get a therapeutic say, but
I was going to say, that was my next question is he loves the trot and he did well with it. It was definitely a good part of our plan of care, but he also had a bit of some weakness in his core. So when he did some trotting, you could see his vertebral column kind of just do, you know, that sacral sitting, that kind of that slouch posture, because he was just not able to really keep all of that together. So we didn't do a lot at a time, but we would integrate it frequently throughout the session.
I think that's fair.
Mm.
You know, it's an alerting activity usually.
Sometimes we've incorporated just doing some joint compressions and making up a little nursery rhyme or a little song to go along with it. If they're needing some of that deep probe after the trotting, and just doing it to the shoulders, elbows, wrists, and fingers. And we found that the kids really enjoy that. To help integrate some of that vestibular might be a little overwhelming.
Brianne, are you sure he only chews when he's on the horse? Are you sure he doesn't chew in other environments, such as in class or in the community?
His
I find
mom
that hard.
said that to me, it seemed like I think somebody else said like a regulating issue. Like typically he would not, but if he was, you could see his anxiety level kind of increasing. Yeah. So, not
I'll
really,
bet you.
but mouthing, I guess, is more the word, mouthing.
Okay, I'll bet you he mouths on other things at other times in his life.
Yeah, I mean, I didn't have contact with his school. His mom was really, really, what's the word? Like, she's just very, like, a very great voice for him, and she was just very active and advocating for him. So she was usually a pretty good, reliable resource. But yeah, I mean, he would occasionally sit there and play with his shirt and things like that. He didn't do tons of mouthing with else while we were in the clinic, but definitely, you know, could be doing it more outside the home.
Yeah. In addition to the trotting and the more concussive gait horse recommendations, I also thought of a couple other things. I have found that some of my kids who also like trotting and a horse with a more concussive gait, like walking, like riding on the gravel road that we have at our clinic as opposed to the sand arena. And so we'll do some more riding around the property. And also they've liked going over a wooden bridge we have because it gives more percussion, more proprioceptive input. And you can make the sounds, you know, clop, 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 or thud, 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 thud as the horse walks over the bridge. And then similarly laying out ground poles and having the horse walk over ground poles just because they step higher and then they step harder. And what else? Riding backwards because it increases the vestibular input, not so much proprioceptive, but just if they're a sensory seeker in general, that could be something worth trying. Thoughts?
Yeah, I mean, he actually really liked going backwards. He thought that was fun. You know what? I didn't even think about trying because we always use the arena. And I didn't think about trying going out, but that was a great idea. Yeah, because and just kind of getting a variety of, you know, new things to see, new things to experience. So that might actually be better for him too. Yeah.
Excellent. Kids and Horses, when I worked in Nevada, now I'm in California at Woodland Strides, but when I lived in Nevada and worked at Kids and Horses, they actually had a sensory arena. And in that arena, they had a little patch of gravel, a little patch of asphalt, and a little patch of wood, like just wood planks that were embedded in the ground. And it was so cute. We would walk over the rocks and we would say crunch, 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 crunch. And then the horse would walk over the wood and we would say thud, 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 thud. And then the horse would walk over the asphalt and we would say clippity clop, clippity clop. And that was a really fun sensory experience with different surfaces.
I love that idea.
Yeah, that's a great idea.
And that was in an arena, so at least you have that more safe, controlled environment. Because it's true, I prefer to ride in the arena because it is safer and softer and all that. But occasionally I have a child where it's like, okay, let's go ride around on the gravel road around our property. Another idea, this isn't for the kiddo who chews, but just in general, since we're talking about sensory, I just want to mention before I have to go, because I have to go in 7 minutes. I have lately been incorporating a lot of heavy work before my clients get on the horse and after, such as when we did a pumpkin theme the other week, we had them carry a pumpkin down the barn aisle. So from their car to the arena, or from the sensory motor room to their car down the barn aisle. And one time we did a travel theme and we had them roll a heavy suitcase. It was a suitcase that we filled with weighted balls. And so that's been really helpful. The other week we had kids rake a pile of leaves and jump into it. We pulled wagons filled with heavy items. So just trying to incorporate functional heavy work around the barn before and after they ride to give them that rich proprioceptive input has been really helpful.
Great ideas, Amy. Yeah, I love heavy work, and carts where you can have them take buckets to the horses, or carry a bucket, or scoop feed and carry the bucket. So you can definitely incorporate the regular equine activities, and they seem to love it, and either, like you were saying, as kind of a pre-activity.
We use our crash pad so much at our clinic. We have a giant gray beanbag chair, love seat type thing. It's a very large beanbag, and we have that in our gym. And we have this octagon foam thing that's for gymnastics, and the kids climb up on it and they crash, and the crash pad, oh, it's so regulating for them. So regulating for them. We also have a couple very large bins with tactile opportunities in them where the kids can actually sit inside. Right now we have corn in our bin, and the kids have been loving sitting in there and just regulating with all that tactile input. In the past we had rice in it. We've done dried pinto beans, bird seed, you name it.
How frequently do you change that?
I try to change it out. I probably should do it more often, but maybe quarterly.
Okay. All right.
I don't have that many clients, and they don't all use it. And I'm just mindful of any kind of spills or germs that might happen when in there, and then I'll throw it away sooner.
Okay.
What do you all do?
I have not had control over that. I have worked in a clinic that had that, and I loved it, and the kids loved it, but I always wondered how they did it. So that's why I was asking.
Maybe using
When I
hand sanitizer before and after each.
That's a good strategy.
We change ours seasonally. Like now it's Halloween themed, and then it will be something else. So it's probably similar to what you do.
Quarterly.
Yeah.
When I worked at Jabber Gym, we did once a year, but that was before COVID times. So I think quarterly is good, and then just being mindful of germs. And also, I don't work Friday through Monday, so the bins get a little rest. And so I figure that's probably helpful too.
Yeah, ours is probably similar, where it's every few months, and we would have a couple of different bins. And then same thing, if somebody had a runny nose, there was no tactile bin, or it would be changed the next day. And then if they could tolerate hand sanitizer, hand washing first, we would do that. But some of the kids can't. So you have to be a little careful that way. My only word of caution for the people who are less familiar with tactile play is some kids can't tolerate it. And you'll see like, you'll call it like finger splaying. You'll see like the hands will kind of open, like if they touch a hot stove. And some kids might be okay with like a dry bean mixture because it's heavy and it provides prop, but something that's a little more sticky like rice that kind of sticks on your hand, they might not tolerate. So there are still individual differences with that. And then I'll watch for like a kid might meet their threshold, and you just have to start figuring out where that threshold is. So usually if you do heavy work before the tactile, it will help with any kids who have tactile defensiveness, so that then if they go touch it, you know, they'll meet their threshold and all of a sudden they'll just lose it and like start throwing and all of that kind of stuff. So I try and stay ahead of before they start throwing my sensory bin material all over the room. But it can be really calming and regulating. Like if you have that deep pressure, they can kind of sink their whole body in there. Sometimes they love that. And then there's those select few with defensiveness where they'll seem to love it. And then they'll all of a sudden kind of hit this wall and it is no more. And it's not good anymore. So helping them identify like when they're getting close. You'll see that more with wet things than with like the dry bins, like Play-Doh and finger paint or something like that. It'll happen more frequently usually, but I just kind of use that with caution. If you start to see finger playing, splaying, or like some other like shaking of flapping of the hands or like wiping more, then usually I'll transition, because sometimes they'll have trouble transitioning out of it if you get to that point, and then you're whisking a bin away as it's being flung at your head. If you miss the boat.
Yes. Thank you, Megan, for mentioning that. Just to add to that also, you never want to force tactile. So if a kid does not want to get in the bin, you never force them in the bin. You never force them to touch it. If they are interested in it, but they want to stand outside of the bin and interact with the tactile, that's great. And also a good strategy can be using a tool to interact with the materials, such as a spoon or an ice cream scoop or measuring cups or funnels. But when they are ready, they will tell you. You know, a lot of times they'll want to keep their socks on, but then a few weeks later we'll see they want to take their socks off. And so that's great, but we never want to force them to take their socks off or touch the material with their hands or to get in a bin if they don't want to. And if they're ready to get out, you know, it's time for them to get out.
How big is your bin, Amy? Do you have like a tub, like a Rubbermaid tub, or what do you use for your bin?
It's a Sterilite brand, but yeah, it's essentially the size of a Rubbermaid tub. It's I wish I knew how many gallons it was. It's from Target, just the biggest.
One of those big ones, though.
Yeah, it's big. Pretty much any kid. I mean, technically I could sit inside it, but just not very comfortably.
That's awesome to have the whole body input. We've used both, like the whole ones, and then I have smaller ones just for playing and scooping in hands. But some of the kids really like the immersion part.
Yes. We've also used horse troughs in the past, but the problem with that is you can't put a lid on them, and I would just worry about mice and things like that. So I like the ones with the lid that snaps with the handles on either side.
Mm-hmm. Especially in a barn.
Yes.
All right, guys, I think we've had quite a bit to discuss here, and hopefully you have, she still with us, she may have left. Hopefully she got her questions answered, and I know I have learned a ton, and I know anybody who's going to be watching this video is going to learn a lot as well. I'm going to follow up with another Facebook post, and I'm hopeful that all of you who offered websites and either educational opportunities, you know, the podcasts and et cetera, if you'll add those so that people can access that once I post it, that would be greatly appreciated. He has a desire to lead the group next month, I am going to take a hiatus for the next 2 months and plan to start again in January. But I'm very open, and I would participate, just not lead one in November. I think December, it's holidays, and everybody's not gonna want to participate. But let me know, if you have an interest in presenting patients or any topic, and we can arrange something if you want to do that in November. But otherwise, I'm going to bow out of leading for the next couple months. So thank you all very much.
Hey, Carol, can I ask real quick? There are some resources that I was going to share from the Play Project. So I don't know if you have people's emails. I don't think I won't have a way to attach them here. And I also want to mention my survey too. So I am in a PhD program, and I'm doing a survey on billing and payment practices for therapists who are using hippotherapy in their practice. And I need some more respondents. We're trying to get a variety of disciplines and states represented. So we're looking at what people are doing as far as if you're using private pay or scholarships, the kind of what methods you're using. And then if you're billing insurance, kind of digging into that a little bit more and looking for patterns of any insurance companies that have a high rate of denials for hippotherapy as a next phase. There's a policy analysis, and all of this is going to be shared with AHA. So they would like us to have lots of information. So I'm going to post the link here, and then I'm also going to share it on the Facebook page again this week. So if you could please fill it out. It takes about 5 to 10 minutes. It's not, I mean, Carol, did you fill it? You filled it out. How long did it take?
Yeah. 7 minutes, maybe.
Yeah. So it's pretty short. So if you could, I know it would be much appreciated. And then as far as sharing, I do a lot with parent coaching, and I actually have thought of some really good resources I have on vestibular, proprioceptive, tactile information that's really parent friendly. And if people would like copies of those, they're just things I pulled together from some of the resources people mentioned. I'm happy to share. So I don't know if you have a list of emails or something. I can send stuff to you, Carol, and you could pass it on.
I have been provided with an Excel spreadsheet, and so I could, cut or copy the emails and have an email list of those and share that with you, Jody.
Yeah, that would be fine. Or you can, whatever works for you. If anybody wants it, I know some of the OTs probably have their own stuff, but maybe let Carol know if you want a copy.
And again, if you could just add that information to a Facebook post on, just different offerings, I think that would be great. We could have a running commentary on different options.
Okay. All right. Sounds good. Thank you. Please fill out the survey.
Yes. All right. Any other burning questions before we close? All right. Well, thank you guys so much. Yeah, I just always learn so much and love and appreciate you guys and your, the input that you've provided and the time that you've taken to share with everybody. So thank you. And if I don't see you before, happy holidays, and we'll plan to get back in the new year.
Thanks, Carol. Thanks for taking this on. You do a great job.
Thank you. All right. Good night.
Thanks, everybody.
Good night.